So we'll start with Dr. Nadauld. Tell us all, where did you grow up?
Well, I was born in the Bay Area of California. I was born in a place called John Muir Hospital, which is in Walnut Creek, California, but didn't live there long. Was really raised in northern Utah, in Provo and Ogden and Bountiful, and I graduated from Bountiful High School. So I'm really a native Utahn. Yeah, go Braves, or Red, or something else now, I forgot. Red Hawks or something like that? Yeah.
Okay.
Yeah.
Okay. Your dad was in education, correct?
Yep, he taught. My dad got his MBA at the Harvard Business School, and then he decided that he wanted to do a little more. So he went and got a PhD in finance at Cal Berkeley, and that's why I was born in the Bay Area.
Why they are.
Yeah, and he jokes that the night before his dissertation defense, someone kept him awake because they were crying all night, and I figured out who he's referencing there. Yeah, thanks, Dad. And then he moved to Provo and was the director of the MBA program at BYU for several years. Okay. And then he went and was the president of Weber State College in Ogden. That's why I spent some time in Ogden and went to Ogden High for a year, was a Tiger. And he helped Weber State go from Weber State College to Weber State University and really enjoyed his time doing that. And then he did some other things for a while and then made his way back to BYU and taught finance classes there. And then ultimately, as kind of the capstone of his career, came down here to Dixie State College, helped them, just like he did at Weber State, helped them transition to Weber State or to Dixie State University. Okay. And now, of course, they're Utah Tech. Okay. So he has a lengthy career in education.
All right. And deep roots. I'm an O-Town boy, actually. Born and raised in Ogden.
Yeah, I didn't know. We haven't made that connection before.
No, I
Josh.
lived there throughout those years.
Yeah, and you're probably Bonneville.
Bonneville,
right? Yeah, a Laker. You strike me as a Laker.
Yeah.
That's why I get.
The
Tigers and the Lakers. The Tigers were kind of rough.
They're like the city
little
kids.
Gruff,
like inner city.
Yeah, I mean, our first day there, I was in junior high, but my older brothers were in high school, and the first day that we moved to Ogden and my brothers went to Ogden High School, there was a big fight that broke out in the school. my brothers got home, and at dinner they're telling the story. They're like, "Mom and Dad, you should have seen it. It was a giant fight right in the rotunda. Like 20 kids involved." And my mom's like, "Oh, what have we done? What have we done?"
Ogden.
Yeah, and it ended up being a great experience.
Oh yeah, that's a great town.
Yeah, it's a great town.
Okay, so you didn't follow your father's footsteps into academia.
Well, I kind of did because I did combined MD PhD training. So I got an MD and a PhD.
So he wasn't disappointed at all.
Well, he actually helped me make that decision. I mean, that's part of the story we could discuss.
Okay.
That's interesting. I mean, when I was in college, I was thinking I wanted to go into medicine, and I had at the time a summer internship between my sophomore and junior years of college, working at the Huntsman Cancer Institute in Salt Lake City, right after it was formed. And so I was working with one of their earliest faculty members, and I thought I wanted to do cancer research primarily as a way to improve my resume to get into med school. And the problem was I started doing the research and I loved it.
Wow, that was prior to college.
Yeah, no, during college,
okay.
During college, yeah. And I loved it. So in between my sophomore and junior year of college, I was doing that.
All right.
And one day, my faculty advisor took me to lunch, and we were going to lunch, and he said, "Now, what do you want to do with your life?" And I said, I want to be a doctor. And he said, "Well, have you ever thought about doing the MD PhD program? Because you seem to like basic research." And I said, "Oh, I've never heard of that. I don't know what it is." And he described it to me, and the basic punchline is more school. So you get an MD.
He described it in a nice way, right?
Yeah, he's like, "Oh,
to make it sound
here's
very
all
exciting.
the advantages. It's so cool, blah, blah, blah." And as I thought through it, I'm like, well, that basically doubles the amount of time you're, So,
oh yeah, then there's the count.
Then there's that.
Yeah.
So med school by itself would be 4 years, but MD, PhD would be 7 years.
Okay.
And then after that, you go on and do residency, you do internship and residency, which is a couple of years, and then fellowship, which is several more years. So, I was basically looking at 13 years after college of additional training.
And you were at The U?
So I went to BYU.
Oh, you're at BYU at this time. Okay.
So I'm in a BYU undergrad.
Okay.
Going to finish up my 4 years, and I'm contemplating 13 more years of training versus 9 more years of training.
Versus no more years of training for
Yeah,
most of us, right?
I know. And so my dad said, here's my dad, the academic, and he said, well, son, here's one way to think about it. You're going to have a career until you're, 65, we'll say. So you could have a 33-year career and, do whatever that entails. Or you do this extra training and you have a 30-year career. And when you're 65, will it have mattered whether you had a 33-year career or a 30-year career? No.
Likely.
I thought that was a pretty compelling argument. Yeah. I fell for it.
Yeah. Yeah, so, he amortized your life.
Yeah, exactly. I'm like,
we'll stretch it out.
Yeah, and then he proceeded to sell me some finance products. So all of this is in answer to your question. You didn't follow his footsteps in academics. I actually did, because then I went to Palo Alto and I was at Stanford, and I was actually on the faculty there for a short time, writing NIH grants, getting grants from the NIH, writing papers. And then even when I came here to St. George, to Intermountain, I've continued to write papers. So I have always had that kind of academic connection.
Gotcha. And you would say that internship between your sophomore and junior year kind of set you on the cancer path?
Yeah, totally formative. Absolutely formative. I loved the science in cancer. I loved trying to understand how these, you're born with and inherit certain genes, and those, for the most part, in all of us are intact and sort of normal, quote unquote, but then during your lifetime you can acquire new DNA mutations, new gene mutations that then form cancer. And that realization was stunning for me, and I just wanted to understand that better, and manipulating genes, understanding gene function was very interesting, and that all started during that internship. So internships matter.
Okay.
They work.
We need to do more of that.
Yeah, we should do them.
Yeah. So my next, let's say, we got up to, I want to take us up to Stanford. When you were at Stanford, were you by then done with the 13 years and now doing like practical and teaching and like being the doctor, or what was happening at that point?
Well, I went to Stanford to do fellowship training in medical oncology. So at the University of Utah, I did my MD, PhD combined training. That ended up taking me 7 years. Okay. And then I did clinical training in internal medicine just for 2 years. And then after you do internal medicine, you can keep practicing as a physician and do internal medicine stuff, or you can specialize. So I decided I wanted to go into oncology and practice in the clinic, and when I see patients, the same thing that I was studying in the lab. So I went to Stanford to get training in medical oncology and to do a postdoctoral fellowship in genomics. And I finished that and spent an extra year there as an instructor. Okay. So working with fellows and residents and doing laboratory work and getting grants and doing all that.
Mix that in with the timing of like the mapping of the human genome, and like did all these things kind of I don't want to use the word culmination yet because that comes later, but did all these things kind of come together like at the right time for you?
Yeah, it was a total culmination of events. So I just had to steal that from you. Yeah, fully. The human genome was completed in 2003, and it took actually took almost 13 years of work to do that, and it cost $3 billion to map one person's genome. It was about $1 per DNA base pair. There are 3 billion bases in the human genome, and it cost $3 billion. So, it was on the cover of Nature, which is a very, maybe the best in the world scientific journal, and at the time in the popular press and in the lay media, the narrative was the human genome has been mapped in its entirety, and this is going to transform medicine. But it didn't initially, because it was too expensive to ever do for anybody else. $3 billion.
Who was that one person?
13 years. It ended up being kind of a mix of people, but Utahns played a big role in that. The contribution of Utah DNA played a big role in the mapping of the human genome. So it didn't really transform medicine initially until about 2009, when some new technologies came on board that dramatically lowered the cost of doing a genome and the time to do a genome. So I arrived at Stanford in 2009.
Oh.
And went into a lab, and we started mapping genomes there. In fact, we mapped some of the very earliest cancer genomes. And I can tell you some other stories about that are kind of wild. But that's what really drove me. It was a kind of this technological advancement coupled to scientific understanding, all happened at the time when I was completing my training. And that presented a real opportunity for me to think about, how do I take this technology, this science, and try to apply it to patients?
So an analogy would be, you caught the wave right then, right?
Yeah.
Right as the wave was coming over, you walked into the right place, having done all the right preparation, waxed your board, so to speak, and so you just nailed it.
Well, I was really lucky, yes. I was really lucky that happened. I mean, I didn't do all this training thinking, I can see what's going to happen with genome technology, and I want to be ready for that. But yeah, because I had done all of that training, I think I was ready to catch whatever wave was going to come. And my dad actually pointed this out when he was giving me this coaching about career length. He said, medicine is kind of in a golden age right now, and if you do this, you'll be really well prepared to participate in that. In fact, he said, I'm kind of jealous. I would love to be doing that right now also. If I had to do, his exact words were, if I had to do my career over again, I would go into what you're about to go into.
Cool.
So I thought, that's all the motivation I need.
I'm gonna say, stamp of approval.
Yeah, I'm in.
That's awesome. So then you're on the wave, and you're out there with the cutting, let's call it cutting edge, the researchers around the globe that are. I think I remember, maybe this was at the time, maybe this was later. I remember seeing, maybe I saw you speak somewhere where you talked about how you and all these researchers would get on these calls and look at somebody's cancer. And discuss, and then try and come up with an idea for which one of the drugs that is available to use on that cancer. And it was almost like the whole globe was talking together to try to figure this out.
Yeah, that was really fun. That was super cool. So, I think the larger scientific community, myself and others included, began mapping genomes from cancer patients around 2009, 2010 at scale. And the problem with that is we ended up getting so much information out of these genomes that we didn't really know how to assess it. We didn't know how to make sense of it. And so we would get all of our best, smartest colleagues together, and we formed what we called molecular tumor boards, which are patterned after standard tumor boards, which have been around in cancer care forever. And the basic concept is, take a patient's case, they're just diagnosed with lung cancer, and get a bunch of docs in the room, surgeons, oncologists, pharmacists, etc., and everybody together as a team can say, here's what's probably going to be the best path for that patient. Here's how to manage them. Well, we said, let's do that, but let's add in the layer of someone's entire genome. And let's figure out, based on their clinical situation plus their genome, how to treat that patient. So we started doing those a little bit at Stanford, but when I came to Intermountain, the very first thing that I did was establish a molecular tumor board. And my good friend Howard McLeod, who's here, was doing this as well. And he and I actually, several years later, ended up forming a company, because it's so hard to do this, that we said, what happened is people just started calling on the phone all the time randomly. Hey, we hear you have a molecular tumor board. Could you review this case and this case and this case? And we're like, middle of the day, at night, weekends, whatever, people sending me random genomes. Hey, can you look at this genome and that one?
Texting you a genome.
Yeah, honestly, that's what was happening. I'm like, I can't look at everybody's genome. We gotta figure out how to scale this or democratize it or something. And that's a separate story that Howard and I can have. In fact, you ought to have one of these conversations
with Howard.
Okay. And talk about that company that's going, called Clarified. But the point is, at Intermountain, we started this molecular tumor board, and we would invite people from the National Institutes of Health, from Stanford, from Harvard, from overseas. We had Israeli scientists call in and weigh in on things. We had Japanese scientists call in and weigh in on things, and it was awesome. And it was totally like groundbreaking, very transformative. And it injected this sense of momentum and innovation that was really important. And it really helped us figure out how to analyze these genomes and how to apply it to patient care.
Okay. Okay. So you started to get positive outcomes and this momentum. So now help us bridge the gap, because that was what about years was that?
That was about 2013, 2014,
okay.
2015.
Okay. And let me morph the words from cancer genomics to precision medicine.
Yeah.
Like bridge that gap for us now.
Yeah. That's a good one. So, cancer genomics really references taking someone's cancer, mapping their genome and saying, okay, here are the genes that are altered in this patient's cancer. And then precision medicine is, here are the genes in this patient's cancer, which targeted or precise therapies could you apply to take advantage of those DNA mutations in cancer? And then more broadly, precision medicine refers to do that in any disease. Why be constrained to cancer? And so that actually is exactly what happened. I came to Intermountain, to St. George, to start a cancer genomics program, start a precision medicine program in cancer, thinking we'll build a lab, we'll map patients' cancers, and then we'll give them precise therapies, and we'll see what their outcomes are like. And we did that. And in the first 3 years, we published papers that said, you get better outcomes. Patients live longer, it costs less to do this, and precision medicine in cancer is the way to go. And after 3 years of doing that, we paused and said, well, now we've built this laboratory. We have this team.
We can see it. It's that reddish building down there to the left.
Yeah, exactly. It's right behind the hospital.
Yeah.
And the big cancer center there that also houses our precision medicine programs. We said, instead of constraining this just to cancer, where else could we apply it? We started talking to some of our other physicians in primary care and in behavioral medicine and ICU, and we got ideas about where else precision medicine could potentially work. And so we began applying it to patients with newly diagnosed depression or anxiety. We realized you could do a snapshot of someone's genome, just kind of a superficial look, and make better predictions about which medicines they'd respond to for their depression or anxiety. So we started doing that. Then our colleagues in the neonatal ICU said, hey, we have all these babies that are born premature. They all end up in the NICU. Some of them get well in a matter of days and leave, but half of them don't. They linger, they languish, and they'll sit here for weeks or months, and it's clear that there's something else going on, and it turns out that about half of them have an underlying genetic condition. So we began rapidly mapping the genomes of babies in the ICU to find out what is the genetic condition that caused them to land in the ICU, and then we could treat them better, their doctors could treat them better. And so we expanded, so that's how we went from cancer genomics to precision medicine. Map genomes in cancer, apply targeted therapies, that is the idea of precision medicine, and now do it in all diseases.
Okay, and I assume you were writing those up, those discoveries and those things
we
up?
we were writing those up, publishing that. Yeah.
I've told people all along that we're leading the world in St. George, and they look at me kind of funny.
Yeah.
They're like, really?
I don't blame them. I know, it's a little hard to believe, especially in something that's kind of cutting edge like medicine, where you'd think, well, it's going to happen in Boston, or it's going to happen in Houston or San Francisco, and it does happen there, of course. But I think it's accurate to say that here we have led the world in things like the application of precision medicine to healthcare, and the advancement of molecular tumor boards, and the introduction of genome medicine at scale. I would say Intermountain has really led the way there.
Well,
because of this program.
And Dr. Lincoln Nadauld has led the way. And I want to make a comparison to our room of 30 or so people. What's the biggest stadium you've sat in to talk to people about this? Like what's the biggest group of doctors and people that have come to hear you?
I've talked to groups of 5,000.
Yeah. That's cool.
Yeah. Yeah, it was cool. No, it was totally lame. It was totally lame. I mean, a more typical size would be, 150. I mean, I've given, and Dr. McLeod has done this for his whole career, but I'll go around and give talks. Before culmination, I was doing that quite frequently. I'd go to conferences and talk to groups of, 200, or go to academic centers and talk about our experience. And, that actually was pretty fun. Mm-hmm. It was a bit of a role reversal. Here's someone from a health system coming to an academic medical center and saying,
telling them how it's done.
Yeah, exactly.
Well, where rubber meets the road right here, people, right?
I mean, I went back and gave talks at Stanford and Harvard and all across the West Coast, UCSF and, San Diego and all across the Midwest and the East, and, back in DC at the National Press Club a bunch of times, and actually went to the White House twice and, talked there. It was a smaller group. Anyway.
So, quick question, because I'm gonna bring us to the next phase. But I did want to ask: has that wave caught on? Has what you've been telling all of these people, is it now a groundswell from coast to coast and across the world, and everyone's now developing on that path?
Well, the short answer is yes. I mean, the longer answer is it took longer than I would have guessed. And that's because of the way medicine is set up. There's third-party payers. And that's the worst. Can you imagine doing business with a customer and then saying, now, who should we get to pay for this? And you just have this great idea, but then you got to go convince some other person who holds all the money that they should pay for it. And it took a long time. Two things took a long time. One was to convince the payers that they should pay for it. The second, which means insurance companies, convince insurance companies they should pay for it. The second thing that took a long time was convincing doctors. You can't believe, the hardest thing in all of healthcare is to change physician behavior. They trained the way they trained, and they want to practice the way they trained. And so to implement a new technology,
did you have to wait for the old crowd to die off?
some of them. We're like, when are you retiring?
We'll take that new gal that's coming in and talk to her. Yeah.
But today it's the standard of care. Precision medicine is the standard of care in advanced cancer. Payers pay for it. The Medicare pays for it. Medicare is the gold standard. If you can get Medicare to pay for something, it's now
ubiquitous.
accepted. Yeah, it's ubiquitous. Okay. So Medicare will pay for it. Insurers will pay for it. But to get there was painful. I remember when we first started in 2013, we would map a patient's cancer genome, we would find a targeted therapy, and there was a drug for it, but the drug was approved in a different cancer type. This drug's approved in lung cancer, but this guy has colon cancer. Well, guess what insurers would say? We're not paying for that. And I was like, but listen.
You'd rather pay for whatever happens to this guy?
Exactly. I'm like, well, okay, great. Exactly. And I would say the cancer doesn't know that it's a colon cancer. Just let's give the drug. And they would say no. So then we would do an appeal, and they would decline the appeal. We'd do a second appeal. They would decline the appeal. We learned this process, and then it goes to what's called an administrative law judge. And so a judge gets on the phone with the patient, and then I would get on the phone, or my colleague Derek Haslam would get on the phone. One of us would get on the phone. We were the two that would do it. The patient, a judge, the insurer, the insurance payer, and then one of us as doctors. And the judge would say, okay, insurer, why do you not want to pay for this? And they'd say, because it's a lung cancer drug and that patient's got colon cancer. And then they would say, okay, doctor, why do you want to do this? And I'd say, because it works like crazy in that kind of lung cancer, and this guy's got the same kind of colon cancer. And then they would say, patient, what do you think? And the patient would say, this is my last chance. This is like all I got. And guess what the judges would say every time? You got to pay for this.
Pay it up.
They would order insurance to pay for it. So we did that about 24 times, and then it stopped cold, and our requests always got approved after that. They lost every time, and then they decided we better quit doing these.
Stop fighting.
We better quit doing these. It's not a good look to be on a phone with a patient sobbing, saying this is my last chance, and a judge mitigating the whole thing. Yeah, exactly. And so they now to their credit, they recognize that precision cancer care is the way to go, and they largely approve those therapies.
Okay, so we got up to the point where you were still full-time, I would say, engaged with IHC, right?
Yep.
More or less.
Yep.
And what was the tipping point into founding something beyond what you had already, we could call a lot of what you did founding, but it was with partners and things like that.
Yeah.
And kind of what was the tipping point that broke you out?
It was that as we were expanding precision medicine into other areas, I began thinking, I think we should just map the genomes of everybody. Let's quit waiting till they show up in a hospital or clinic sick with something. Let's just do it preemptively. And I started talking to the CFO of Intermountain because I knew this would be expensive. And he's like, well, that sounds like a great idea, but who's going to pay for it? I'm like, well, that's why I called you. What do you do? Why do you even have this title? Why are you asking me that?
You're the money guy. Master of coin?
Yeah, but in seriousness, he's like, it's not bad. It could actually work. So we end up looking all over the world saying, who could we partner with on this? And we found this organization in Iceland that had been mapping the genomes of their population. And it's an organization called Decode Genetics. And their founder is this Harvard-trained Icelander who's a geneticist. And he started mapping the genomes of Icelanders. And he has mapped 200,000 of the 300,000 people in Iceland. He basically knows everything about the population genetics in Iceland. He has one major problem. He's not allowed to call those patients back and say, here's what we found, and it's going to cause a problem for you, and you better do something about it.
Why?
Because the government doesn't want him to. They have these...
Like HIPAA type thing?
Yeah, it's kind of their ethics boards decided that would cause too much stress for patients. And I said, well, I think the opposite.
Yeah, maybe a little more stress when they find out later.
Yeah, like, wait a minute, I got cancer all over my entire body, and I could have known that 5 years ago, and you prevented it? That's more stressful.
Agreed.
Yeah.
All right.
So, fortunately, in the U.S., our ethics bodies agree with what I just said,
okay.
And so, we could do it here. So we called them and said, hey, let's partner, because you're really good at mapping genomes times hundreds of thousands of people. And we have the advantage that we're at a health system where people want to know this and our ethics boards agree with us. Why don't we do this together? And by the way, we think your parent company could help pay for it, called Amgen, which is this big pharmaceutical company.
Okay.
And they agreed and said, fly over here and talk to us. So in February of 2018, we flew to Iceland. Have you ever been to Iceland?
No, I have not.
Anybody here ever been to Iceland in February?
Sun doesn't come up, right?
Don't go to Iceland in February. That's what I learned.
Eternal night?
Yeah, well, it was like, 3 consecutive days of sideways rain and freezing cold and, my socks soaking wet from rivers of water running down the streets, I turned to my traveling companions and I said, oh man, the blessed people of Iceland had one chance to name their country. And they got it right, first try. They totally crushed it. This is Iceland. Anyway, a year later, we came to an agreement, we signed an agreement, and we launched a study at Intermountain Health for all of Utah, Idaho, Nevada, and some of the surrounding states called Heredigene, the Heredigene population study. And the concept was, let's map the genomes of hundreds of thousands of people, and let's find, for example, everyone in the population that has an inherited, known predisposition to develop cancer. 15%, it's going to be more than that, but right now, about 15% of all cancers are inherited, meaning we could know it. We could know the gene that you have, and we could know which cancer you're going to get, and then we could do surveillance and make sure you don't get that colon cancer, or if you get it, it's very early stage, and we treat it and cure it simply. Same with breast cancer, same with a variety of others. Don't you think it's amazing we don't do that already? How is that not standard of care? So it's not. And we said,
I don't know why.
Yeah, I know.
Do you?
Yes, I know why. I know why, and it's you don't want to know the answer.
Is it the old doctors?
It has to do with payment.
Oh.
It has to do with payment.
Yeah.
Always.
Yeah, follow the money. Okay.
So we said, okay, fine. We'll launch a study, and we'll do it as part of a study, and then patients can decide, do I want to know the answers or not? So we launched Heredigene, and I have to say we just eclipsed 200,000 participants in Heredigene. It is the largest healthcare center genome study in the world, or ever conceived of. So that's really cool, and it's been really successful. We've called patients back, and Dr. McLeod has a lot of experience with this. In fact, you ought to have a follow-up conversation with him on that as well. And we've called patients back and said, we found a gene, would you like to know the answer? And they say yes, and we give them the answer, and it changes their life because now they're empowered. So all of that is what led me to answer your question.
Mm-hmm.
What was
leading up?
Yeah.
The
What
catalyst.
caused you to found Culmination?
Yeah.
During Heredigene, I realized the answer to not only precision medicine, but to healthcare 2.0 and to innovation in medicine is to form the largest data sets possible. Get data that is totally comprehensive, including genomic data, make it anonymous so that it's compliant, strip all of the patient identifiers out of it, but form very large data sets that will inform on discoveries and generate insights that totally change the way we practice medicine. And that this is possible with large data sets. And that was the kind of aha that came from Heredigene. And I noticed that it was happening in the financial sector. You know, the financial sector has largely been transformed by the aggregation of large data sets. And many of the fintech companies that are spun out now and are having success are because of their, basically unfettered access to data that informs them on their technologies. And the same is true in energy. And all of these different sectors, these big markets have been transformed by the development of large data sets, and healthcare has never done that because there are all of these understandable concerns about privacy. So we worked with the biggest team of lawyers you can find to figure out how can we form the largest possible data set in a compliant and safe way. And I said to Intermountain Health, I want to go found this company. Let's take all of this data that has been stored in your biospecimens. That's another trick to this.
Okay.
And let's form these large data sets to make discoveries that can transform medicine. And I said the reason that I want to do it with Intermountain is because they have been saving all of any kind of tissue collected from a patient, a biopsy, anything that's come out during a surgery, they have saved and stored to the point that there are now more than 5 million biospecimens sitting in a warehouse in Salt Lake. And those biospecimens are anonymized, so we don't know who it belongs to, but you can pull DNA out of that, map a genome, and say, aha, here's a genome that led to a patient having, this skin condition, or this intestinal condition, or this brain condition, or whatever, and here are the medications that patient got, and here's what happened, and here's the outcome. And we can now take a breast cancer off the shelf from 2007. Here's this patient was diagnosed with breast cancer in 2007, but guess what? I can look backwards and say, they started on aspirin in 2001, or they had a stroke in 1999, or they ended up having a heart attack in 2015. And that entire journey, especially when you add DNA information on top of it, becomes incredibly powerful. Statistically, it gives you power to identify all kinds of associations that have never been identified before. And now we can take those insights and apply them back to healthcare, change the way the patients are treated, and it's healthcare 2.0.
Okay, so you're partnering with them. And just a side question, do all healthcare institutions store all the leftovers?
No.
Or why did they do it? They're just super meticulous?
There were a couple of influencers, the original influencers, even before social media. These are the OG
Back in the
influencers
day,
back in the
okay.
day. Yeah.
Okay.
Who, one was a pathologist, and she had this crazy idea that, hey, let's not throw away all these samples because I think they're going to be useful in the future, but she didn't know what for.
Okay.
She retired in 2010, and as her legacy, she said, I want all these millions of samples to keep being saved because somebody's going to figure out how to use them in the future.
Wow.
One of my very first trips Intermountain, when I was contemplating coming here, I went and saw that. They took me to a parking garage in Salt Lake City, across from LDS Hospital in the Avenues, if anybody knows where that is. And they said, here, you have to put on a hard hat. Why am I putting on a hard hat to go see biospecimens? We walked down like below ground, 2 stories, and in this old dusty underground parking garage, they flipped on the lights, and there were rows and rows and rows and shelves and shelves and shelves of biospecimens that had been saved.
Wow.
And it was because this pathologist said, I think someone's going to need to use these in the future. That was it. That was her entire vision. Save it for tomorrow's set of scientists.
She was highly influential because somebody gave her a parking garage.
Yeah, that's right. And so when I saw that, that was the inkling of, I think these could be useful. And then I went on, did all this precision medicine stuff, did this population genome stuff, and realized, oh my gosh, we're mapping the genomes of currently living patients, and there is a whole bank of millions of patient journeys. We could map their genomes and already know everything that ever happened. And that gives us the view to a 5 million patient population and all of their outcomes.
Okay.
So that other health systems don't do it. Kaiser Permanente has been incinerating all of their samples for decades because they're worried about patient names on the blocks. So Intermountain had the innovation of take all the names off and just give like random number identifiers. That seems like a pretty simple solution. So not everybody does it. In fact, nobody does it. Intermountain has the largest in the world.
Okay, so when did this founding take place? All this stuff came together, you decided, okay, I'm gonna pitch my partners, but when did you go off on your own and live in the van and start in the
Down by the river?
garage? And yeah.
It was, I started pitching it in 2020, the spring of 2021.
Okay,
And then we founded the company on March 31st, 2022.
Okay, so what's happened since then?
So since then, we have done a lot of things. We have formed the team. We have this brilliant blue ribbon, bulletproof team that we've brought together from all over the country. We have built this very large data lake, populated it with millions of genomes, millions of journeys, and we have, we now have trillions of structured data points that we can search across. In fact, we've been partnering with AWS because we store all this in the cloud. We also have an agreement with Microsoft, and we also have an agreement with NVIDIA. So we're partnered with all three of those.
You're playing with everybody.
Yeah,
were you playing with NVIDIA before they got cool?
Yeah, we were.
Nice.
Yeah.
I hope they gave you some stock.
Well, they don't like to. They don't call us as often as they used to. Now that they're all cool.
Yeah, they got busy.
They're starting to call us again because we're starting to be cool too. So, trying to keep up with them. Yeah.
Nice.
Anyway, so we've been building this data lake. We've built the team, built the data lake, and now we're talking to all of these partners who want access to the data to ask their interesting questions. We basically have enough data that we can answer questions for most people out there, including biotech. Biotech companies have a lot of questions about their technologies, how to apply their technologies. Pharma companies have a lot of questions about what is the next generation of medicines they should be producing, and we can help them answer those questions. So we've been getting a lot of commercial traction, and that's what we've been doing over the last year, and it's been a ride.
I like the terminology data lake. We've often used the word vault as if it's some sort of closed box thing.
Yeah.
I like the idea of a lake because it just seems big and mushy and everything's all in one place.
On it.
That seems cool.
Yeah.
And just for anybody that doesn't know the NVIDIA reference, they've been the masters of the graphics card since I was a video gamer for a minute, way back in the day, right? So they make the graphics cards, not the processors, but the processing power in a graphics card, which is nonlinear versus linear processing power. And it turns out that these large language models really thrive on the nonlinear power of the graphics card versus like a AMD Athlon processor. So NVIDIA is one of the most valuable companies in the world. Almost overnight, because they really have the market cornered on the graphics card technology and industry. So that's why they're so exciting. But super exciting for you because those cards are probably what are needed to do all of the question asking of the lake.
Yeah, and actually they're excited because they're going all in on genomics because they realize what those cards are really good at is looking at big data sets. So they want to do some of that internally. So your point about large language models is not lost on us. We began realizing as we formed this data lake that who's really going to win in AI, this is now just me talking, kind of my own.
Freelance,
yeah,
go ahead,
whatever.
riff.
So ignore it. I think it's going to be the application of AI to unique data sets. It's not just inventing a novel algorithm or language model, because those are, I think, largely going to harmonize. I think it's applying it to unique data sets that those language models haven't had access to before. And that's what we have. So, we just hired our VP of AI, and he now has a team, and they're building the models that will sit on top of this vast data lake and constantly churn, looking for the unique associations, because they can assimilate billions of data points at a time, these models, and whereas we can't. And they will churn out, and have already begun churning out, some of the insights that exist that we couldn't make.
So you're starting to get momentum. You've mentioned partners are coming in. You threw out a couple names like Microsoft and so on. So now let's kind of to wrap it up a little bit, we're close to the end here. Let's get into the the founder. Let's call it numbers. What is this going to mean? Like, what does this mean now? What is this going to mean for the growth of this company? And maybe we could tie that into St. George, Tech Ridge. What is your vision for the next 5 to 10 years of the growth of Culmination and what that looks like as a startup company that grows into a big company?
Well, I mean, so we currently have 65 full-time employees on our payroll,
Okay.
which is
Yeah.
Good.
That's good for like, what, year and a half?
Yeah.
Yeah.
Yeah, since March of last year.
Mhm.
And, I don't think this is a 10,000 employee company. I think this is like a couple hundred, because it's largely a data and technology company.
Okay.
But what I really think is going to happen is that companies like this, data companies, technology discovery companies like this attract outside investment. And I anticipate they'll attract investment from pharma and from biotech. And so that will mean investment coming in not only to the local community, but to the state. We have headquarters both here in St. George, and also we have space in Salt Lake.
Okay.
And we have a distributed team. We have team members in Philadelphia and Chicago and San Francisco, and we just hired someone in Texas and another person in New York. So we have
The Blue
engineers.
Ribbon team,
Yeah,
right? They're all
the
over.
Blue Ribbon team.
Yeah.
The majority of us are in Utah, but we've got engineers that are all over because, I mean, you know that. You know how that goes. They're cool. And so that kind of investment pouring into our local community, I think, is going to, if we can keep succeeding, then it'll make a difference. And I would love to see Culmination have a presence here on Tech Ridge, a physical presence, a property, and continue to grow and provide jobs and economic growth for years to come.
Okay. Anybody been dying to ask a question? Mike?
What does it take for someone to get their genome
Mapped?
You said like you've done over 200,000.
Yeah.
What's that process for an individual?
So right now, Heredigene is still going on. So anybody in this room or anybody anywhere could walk over to the Intermountain Health St. George Regional Hospital, go on the first floor and say to the lab and say, I want to be in the Heredigene study. They'd say, great, sign this form, give us some blood, and we'll call you if we find anything. So and it's actually at no cost.
2 weeks ago, I was at the Instacare over on Sunset, and a gal walked out and sat down next to a patient and said, we're going to draw your blood. Let me tell you about Heredigene.
Yeah.
And she and sign this paper right here. And
Yeah.
because they were going to draw the blood anyway,
Right.
they just jumped into the study.
Yeah, well, just let us take one extra tube while we're at it.
What is the cost of that?
There isn't a cost.
No, I mean,
No, like the real
like
cost.
if we wanted
Oh.
to do that for all of you.
Oh,
Yeah.
for all of you.
yeah. Well, I mean, you can map a genome. You mean like what does it cost to map a genome, for example? It's under $1,000 now. It's many $100s. Although the latest iteration of this technology that does genome mapping just came out, and if you fully load up one of these new genome mapping machines, the promise is that you can get it down to a couple $100s a genome. So
We could easily go private and we wouldn't even have to worry about insurance.
yeah, people do that now actually. So there are some people who say, I just want to map my genome, and I don't want to do it as part of a study, and
Here's my money.
here's my money. A lot of people will do, instead of mapping their entire genome, they'll just look at like 100 or 200 genes. They say, I want to know, like, do I have a predisposition for cancer or Alzheimer's or whatever? And there are quite a few commercial companies who will do this for an out-of-pocket cost of $200. I mean, you could do that today online.
Peter?
I think of you as like the nation biotech industry in St. George. Like this is always how these things start. Like,
Yeah.
Dad happens to be at Dixie State, so
Yeah.
you're like, St. George is kind of cool. I'll
Yeah.
go to Dixie Regional Hospital, and then like things kind of snowball,
Yeah.
and all of a sudden you're here, and there's several smart people in this room, and 50 plus or however many smart people in the community working on this stuff, the Cancer Center. So my question is like, how do we snowball that? Like, how do we snowball? What can we do for you as a community to make it so that it's like not just the Cancer Center, it's Culmination, and then it's not just Culmination, it's another biotech company
Yeah.
and another biotech company, and turn this into like an industry that's here?
Well, I love that question, and I love the intention behind it. I have to say Utah Tech has done a great job of that. Utah Tech has been talking to Intermountain and to Culmination. Aaron's back here, and he understood this a few years ago. And I think there are a couple of things. So, Intermountain and Utah Tech have jointly been sponsoring an internship, a summer research internship at Stanford for like 10 years, and been sending students there every year. And those students have gone on to get into medical school and PhD programs and so on. And they're, so they're kind of the next wave of trained scientists. But then
pull them back in.
Yeah, and then I think a little more granularly, Utah Tech also formed this new, and Dr. McLeod can tell you about this new precision medicine center using zebrafish as a model system that will train the next generation and I think be a way to analyze some of this data. But at Culmination, we have this in mind. Our thought is, can we, our goal, frankly, is to grow the company enough that it is a significant economic spoke in the wheel here locally and gives rise to other, service companies or companies that frankly could even spin out of Culmination. That would be a dream scenario. We're not there right now, but that could happen.
That is our dream scenario.
Yeah.
Right.
Yeah.
So you've got the genome that you've been part of mapping, and then the next step is then, okay, what do you do with the information? And you're gathering those from biospecimens and then also actual patients that you're helping. Where's the connection with the actual treatment from drugs? Where's that incentive to figure out that this drug helped with this cancer? Like, is it up to the drug company to say, we've tested it and we know that this works best, and then they're going to the physicians to try to get them to use it? Or is it based on the physicians, the treatment that they've had, and that database is what's pushing this is how you treat this type of cancer?
Yeah, I mean, there are two sources to that. Nationally, there are publicly available databases. There are published results to clinical trials. Pharmaceutical companies are required to publish their results to clinical trials, and they do that. And so that's helpful information. At the level of Culmination, one big advantage that we have is that we have that information for our own population. It's de-identified. We don't know who it is. It's anonymized, but we know that patient X, for whom we have this colon cancer specimen and we've liberated the genome, we know which drugs they got and how they responded to those. And so that ends up being very powerful.
So you're making the connections.
We're making the connections, yeah.
Okay.
Yeah, we think that's one of our major contributions, is making all those connections, those ahas that have been missing for years because these data sets have all been siloed. Pharma has maybe data just on their drug, but they don't know anything about the competitor's drug. But here we sit and we have information on all the drugs.
I'm going to interject my question real quick. So follow the money, because that's where we know that's where everything goes.
Yeah.
How does precision medicine, how does the money align with precision medicine in a way to revolutionize our healthcare?
Well, in standard practice in a health system, it's tricky because it's the third-party payer, it's the insurance that pays for it. So they're willing to pay for certain amounts of precision medicine, but not all of it. Mm-hmm. And so it becomes a bit of a chicken and egg. They keep saying, well, we want to see all of the data. Mm-hmm. And then, health systems say, well, we can't generate all the data because you won't pay for the testing or the drug. And then, so there's this kind of fight that goes on. One of the goals that Culmination has is we have all the data for what happens when the patients with certain journeys receive precision medicine compared to those who didn't. And we can provide that to precision medicine companies to say, here is the supportive data you need. Show this to payers, and that will convince them. So I think it's all about having the supportive data that proves it. And that's a major reason that we formed Culmination.
And you've become good at dealing with frustration in your life and patience as you wait for these things to finally go.
Yeah, I mean, I think that's like a key ingredient anytime somebody tries to do something new. Innovation is fraught with obstacles. I mean, these are cliches that you've all heard, but I think not letting the obstacles slow you down or weigh you down or frustrate you is key. Resilience. If you're going to be an entrepreneur, I think resilience is probably the number one quality to have.
Gotcha. Hey, we are out of time, but you can grab him afterwards if you want to ask a specific question. Let's give him a hand, please.